Hi, this is Mary Kelly, and I'm presenting on a patient with wrist pathology. I chose this case primarily because I learned a lot from it, because it involved both physical intervention and there's a huge psychosocial component with it as well. The patient was a male, 59 years old, retired, right-handed, and came with a referral for drop wrist, and primary complaint was that he has not been able to extend his right wrist or fingers for the past month, and pretty low functioning as indicated by the photo score of 33. Primary complaint as far as function goes was that he's not able to button his shirt buttons, tie his shoes, open up doors depending on the handles, write anything, pick up pens and whatnot, so pretty limited function. There's no complaint of pain anywhere and no occurrence of numbness or tingling ever, and primary areas at the right wrist and hand. All the structures in that area. The primary hypothesis I was focusing on are right here, so looking at radial nerve peripheral distribution at different levels or different branches, and then different structures that might entrap on that nerve. Couldn't ignore the cervical root level, and post-polio syndrome is really the only non-musculoskeletal condition I can think of that presents unilaterally and results in just onset of paralysis out of nowhere. Aggravating factors, this is just a constant lack of wrist and finger extension, and nothing changes that. Over the past month he's had no change. He describes his mechanism of injury as falling asleep, and his arm was draped over a chair, and he was there for a long time, 8 hours or more, and when he woke up, couldn't extend his wrist or fingers. So that stayed the same, and felt that having diabetes, being a smoker, and diagnosed with clinical depression and alcohol use were significant for this condition, just due to tissue healing and time frame. He had not gotten any previous treatment for it because he was getting back surgery and he wanted to wait, so he waited a month before he came in for physical therapy. Just some repeat on the health histories. No major red flags, and yellow flags we already went over. As far as depression goes, he's a smoker. No diagnostic testing done, no nerve conduction velocities test, and he does not take any medication directly related to this. So take a time out, kind of pick some subjective asterisks and post on Moodle, and we'll continue now on to what I chose as my subjective asterisks. These were really kind of his primary complaints on that day when he came in: picking up a pen, buttoning his shirts, and tying his shoelaces. So I decided to focus in on that. After that interview, I started to hone my hypothesis into focusing on radial nerve and a neuropraxia or compression injury, even though neuropraxia usually resolves within 2 to 3 weeks, just due to some of his negative prognosticators that maybe this was just slower healing, but ultimately mechanism of injury and just functional limits. No pain, so rule out supinator syndrome, and no denies any polio in the past. So I ruled that one out pretty quickly. To get a little bit more for here, clinical reasoning, it is severe, really. Some trace movements, but also severe as far as how much it affects his his function. Irritability minimum, focusing on neuromuscular system, and just based on it being a month, felt that he was in the stage of tissue healing, so subacute, and the condition has been really very stable. So these are the primary tests to rule in or out some of the hypotheses, using sensory testing, and MMT for just level of lesion, and ULTT to rule out any entrapment, see if there's any change with putting that tension on. Excuse me. And if I were to defer anything, it would just be the full cervical and shoulder exam if the clearing test was negative. Has pretty severe forward head posture, round shoulders, almost keeps looking at the ground while we're interviewing him. No shoulder restrictions, but just really hard to maintain a neutral wrist position with any sort of gripping activity or handshake. His flexors kind of over dominate. Cervical, spine, shoulder, elbow were all cleared. The sensory exam showed no dermatonal pattern of sensory loss, as well as myotomals not consistent with the nerve root level or insult. He has preserved his DTRs. Well, they are diminished. They were the same on both sides for brachioradialis and triceps. All the upper motor neuron tests were negative, as well as the ULTT. Shows no joint flexion contractures. The only range of motion loss was when doing muscle length for the finger flexors. And finger flexors also showed just a lack of motor control. Really, if he goes to flex his fingers to a fist or at all, he has a hard time not going into wrist flexion. It kind of strains not to go into it. So I put this picture here of that's kind of what he looks like when he's actively flexing his wrist. When he's not, he just kind of hangs out there. This supinator catch sign is more of a clinical test for neurologists. Use it to check for pseudo-neurological signs. So if somebody has a true radial nerve palsy, they will present with, when they start here and then go into supination passively, the hand will remain extended a little bit just due to the tension of the flexors, and this would be a pseudo sign. I found this when I was doing some research. There's really no actual diagnostic use for it for us as physical therapists, but it was interesting to do this on the patient because it was quick and harmless, and he did actually, the inclusion criteria for doing it was that there was no sensory loss, that they still had brachioradialis and triceps DTR preserved, and nerve conduction velocity tests were normal. So he didn't have them done, so we just did this test, and he was positive. He came in here and still maintained some extension. MMT broke this down by the different motions at the different joints. So looking at more of that gross movement. Later I'll get into just more of individual, some of the extensors, but you can see that really with the extension here, not just trace ability in most of the extension, and compared to 5 out of 5 on the right or on the left, and in some of the other motions. So take a time out and post your primary hypotheses, any objective asterisks, and any questions you might have, and I'll hope I can answer them. Thank you.